macular hole, it is going under the retina. Now air fluid exchange was done, and finally 20% SF6 was injected. Now this was the result. Before surgery, it was a large macular hole, visual acuity was less than 6/60, and after surgery this hole was closed and the vision improved to 6/12. A total of 12 patients were included in the study. Male to female ratio was 1:2. Mean age of the patient was 59 years. Mean macular hole diameter was 755. Complete anatomical closure was obtained in more than 90% of the patient, and visual acuity more than 2 lines was attained in more than 80% of the patients. Now, in spite of high success rate of macular hole surgeries with macular hole with greater than 650 micrometer remained a challenge. Macular hole closure is a multifactorial process. Removal of vitreous and ILM induces gliosis and relieves tractions that lead to reapproximation of the hole edges. Macular hole with surrounding subretinal fluid were more likely to close. Now this was attained in this study by injecting the BSS by the fluid needle, and macular retina is freed from the underlying RPE by subretinal fluid by the jet of the back flush needle, and once the air fluid exchange and 20% SF6 was injected into the vitreous cavity, the hole closed. This study revealed 91.6% of closure and 83.3% of visual acuity improvement. A similar study conducted at LRBT, Karachi, it revealed 88% closure and visual improvement in 27.7% of eyes, but they had included previously failed macular hole surgeries, while our patients were the primary macular holes. And another surgery done by another consultant, it revealed 87% of closure rate and 94% of the vision improvement, which is comparable with our study. So in the end, I would conclude by saying that pars plana vitrectomy with ILM peeling followed by macular hole hydrodissection is a safe technique with excellent results in anatomical closure and visual outcome in large macular holes greater than 650 micrometer. However, another study with larger sample size is required to get the exact data. I thank you all for your patient listening.
Thank you very much, Dr. Amir. I think question answer session will be in the last, because our foreign delegate is waiting in Gaza. So I would like to invite Dr. Muhammad Ahmed Tawfiq from Egypt to present his talk on challenges in macular hole closure. Dr. Ahmed Tawfiq. Muhammad Ahmed Tawfiq.
You hear me? You hear me?
Yes, we hear you.
Good evening, everybody. I'm sorry that I'm unable to attend physically because the situation that I faced here in Gaza Strip, because we are stuck now. Just we don't know which time we will go back to our home. And thanks to Dr. Amir to give me the chance to being with you virtually also. So I'm really appreciating what you are doing. And my presentation starts sharing. But the host need to be able to give me the ability to share the screen, because I'm not able to share the screen. If the IT allow me to share. Do you see the presentation now?
Yes.
Perfect. Perfect. I will present a single case of a double macular hole. It's a complicated case. First, this case is presented to another surgeon for a case of submacular hemorrhage. He intended to do subretinal injections of TBA. And that what you can see now is the post-operative pictures after 2 years of the surgery. It's keeping safe until 2 years of the surgery. The first OCT that that you see in the upper left corner of the screen is the pictures after the surgery, and keep it like this for 2 years. Large macular hole with atrophic bed and double hole, one small hole and one large hole. And the patient, when I see it at this level, I told him we just need follow-up, because every surgery, whatever we are doing, we don't have visual prognosis, significant visual prognosis. But after 2 years, he developed a retinal detachment. The OCT showed the detachment, and the mosaic pictures of color photo show the detachment. But we have a 2 hole, one small hole and one large hole. So I'm thinking to go for repairing the surgery using the ILM flap for the small hole. As you can see, I tried to trim the hole, the ILM very carefully, because I didn't need to lose the flap, and use it as an envelope technique or inverted flap technique to close the small hole. As you can see, it's in a macular area. But what I'm doing is staining underneath the PFC and doing the peeling also underneath the PFC. So very carefully doing the flap for the small hole and going to do the graft for the larger hole. What my technique to doing the graft is to using a bimanual technique, grasping the flap with the forceps and doing the cutting of the flap, not 360, keeping like 10 to 20 degree, don't cut it and keep it, and flattening the flap again with the PFC. As you can see, I cutting the flap and then going underneath to release a couple of hours and leave like a pedicle. Don't cut it, leave it like this. So by manual technique, such a technique is amazing because you have a very controlled cutting and very control of the amount of the size of the flap that we need to cut. So leave a small pedicle and don't cut it, and then flat the retina with the PFC. A complete push the PFC and flattening the retina. As you can see, this is the small pedicle keeping the graft stable at this position, and what I'm doing, I'm rotating the flap underneath the PFCL, making the pedicle, make the flap stable, and then cut the pedicle. If you do this technique, it's very controllable, and the flap will be stable. So you can just cut the pedicle by a scissor and moving the flap underneath the PFC very gently to twirl the macular area. As you can see here, I just put it over the hole. So for me, the bimanual cutting of the flap in a detached retina with such a technique to keeping the pedicle, small pedicle, to stabilize the flap when you flatten the retina with PFC and rotating the flap and cutting the pedicle, moving the flap over the PFC, give you this stability and easy moving of the flap over the surface of the retina without moving. And at the end, direct PFC silicon exchange, I usually use the sandwich technique, not direct PFC silicon exchange. And this is the second day post-operative. The ILM flap is over the small hole and the graft over the large hole. And this is the 1 month post-operative, the flap starting creeping and connecting to the neurosensory retina. And thank you. Just I need to demonstrate how you can deal with the complicated double macular hole.
Thank you very much, Dr. Muhammad Ahmed Tawfiq, for very informative and very wonderful presentation from Gaza. Anyone want to ask any question from?
Thank you for a lovely talk. My question is that how do you actually measure the size, the correct size, and what are the problems if you over or undersize the graft? And have you faced any challenges with the oversized graft?
The problem will not be if the flap is oversized. The problem will be if the flap is undersized. If the flap is oversized, no problem. The problem is the flap is undersized. So the measurement will be according to the disc diameter. So you can see the disc and you can measure the hole according to the disc. and make it a little bit large, because if you have a larger flap, never mind. If you have a small flap, the problem is there if you have a small flap. And I will never embed the flap underneath the macula. I keep it over the hole. And also there is a small tip here. When you put the PFCL and keep moving the flap, the graft over the surface of the retina underneath the PFCL, and starting to do fluid air exchange as a sandwich technique, or direct PFCL as a direct PFCL exchange, do the last bubble of the PFCL a little bit after like 8 minutes, 10 minutes. Take your time to release, to remove the last PFC bubble, to make the PFC act like a temporary adherent for the flap over the surface. Don't go rush and remove the PFCL, because it gives a chance to the flap to move if you quickly remove the PFC over the graft.
Thank you.
Thank you.
A very good presentation. What was the orientation of retina? I think it was upside down once you were placing it.
What is the orientation of the retina?
Yeah, because
I didn't understand the question.
Once you made the flap, you put it on under the PFCL and cut the pedicle and took the retina and placed it there. And once you were putting you were cutting, it was upside down, and then you cut the flap.
No, I understand your question. You mean the orientation of graft, you know?
Yeah,
orientation of the graft, upside down. Yeah. This is an important point to keep the orientation, because I didn't cut the retina 360. I just hold it by the forceps and cut it in this direction and this direction, and just keeping the small pedicle, and leave it like this, and put the PFC to keep the retina upside down, not flap. This is an important point in this technique, to keep the retina upside down, like in upright position, not upside down. Okay, so this is an important point. By grasping the retina with the forceps to keep it like this, you just cut it, the retina is detached. Don't do the cut underneath the PFCL. If you doing the cut underneath the PFCL, you will not have the control on the graft. Maybe move underneath the PFCL, and then when you stop, just keep it, just hold, and PFCL, flattening the retina, and keep it like this. So rotation underneath the PFCL, or cutting the last pedicle underneath the PFCL, it's easy, and you don't have the chance to flap.
I think we can have a laser mark as well for orientation. Either it's a superior or inferior. We can laser.
The laser and diathermy, if you have a bimanuality, you can avoid it, because if you have a bimanual technique, you can avoid the visits, and also the PFC make as a temporal adherent to the bleeder if you have a bleeding from the vessel. Yeah, it's all option you can get it, either diathermy or laser, or you can keep it oriented by the forceps. All the tips can work here.
Thank you very much. Any question from the audience? Ahmed?
Thanks very much, Mohammed, for joining, and it's good to see you. Yeah, thank you. And
Thank you so much, Dr.
I'll hear
Ahmed.
more tomorrow.
Inshallah. See you tomorrow, inshallah.
Now,
so next is Dr. Faisal Murtaza, and he will be talking about optic disc pit maculopathy, when to treat, how to treat, our experience with ILM, plug and plug the serum.
Assalamu alaikum. Welcome all the delegates in a very informative session on macular surgery. My first talk is on optic disc pit maculopathy. An optic disc pit was described by White in 1882. It is congenital anomaly of the optic disc complicated by maculopathy, assumed to be due to imperfect closure of the superior edge of the embryonic fissure. This is a histology. This is a herniation of dysplastic retina into a collagen-rich excavation that extend into subarachnoid space through a defect in lamina corposa. Optic disc pit maculopathy. स्लाइड्स नहीं आ रही इसमें, दोबारा से करो. This is my presentation. Sorry for the audio visual problem. This is the optic disc pit anatomy. It is congenital anatomy, anomaly of the optic disc pit, which is described by White in 1882. This is histology. And optic disc pit maculopathy is characterized by intraretinal and subretinal fluid at the macula, and which is associated with progressive visual loss. Source of the fluid is considered to be either from the vitreous, CSF, leakage from blood vessels at the base of the pit, or leakage from the choroid. These are the hypotheses. Epidemiology is incidence 1 in 11,000 people. Asymptomatic on routine examination and may present with visual field defect, could be central scotoma, could be paracentral arcuate scotoma, and could be metamorphopsia. On clinical examination, you will have infratemporal. If the optic disc pit is infratemporal, you will have a round elevation on the macula. Diagnosis by fundus photograph, OCT. Previously, it was treated by oral steroids, then laser photocoagulation at the temporal margin, intravitreal gas injections, combined intravitreal gas injections with the photocoagulation at the temporal margin. Then macular buccal were tried. Then vitrectomy techniques with laser and gas tamponade, vitrectomy with laser and gas, with gas no laser, and with silicone oil. These are the different treatment options. Then there are different other techniques like pars plana vitrectomy with autologous platelet-rich plasma and gas, pars plana vitrectomy with collagen plug, inner retinal frustration. Platelet-rich plasma in ocular use, it used in dry eye, post-LASIK, non-healing epithelial defects, macular hole, and optic disc pit macula. My first case report is autologous platelet concentrate. It was a 25-year-old lady present with gradual painless decrease in the vision, and visual acuity was counting finger. Fundus examination shows dome shape elevation. Pre-op, you see the dome shape elevation with the central macular thickness up to 823. This is the surgery in which we perform pars plana vitrectomy, induce the PVD. After inducing the PVD, can we have faster? इसको फास्ट कर सकते हैं? बड़ा कर दीजिए.
Click start.
क्योंकि और वीडियोस भी हैं.
Click pause. Click start.
So induce the PVD and then complete the vitrectomy. So fast नहीं कर सकते. After completing the vitrectomy, we perform the air fluid exchange, and then we inject the autologous platelet-rich plasma on the optic disc pit. Fast नहीं हो रही. We inject the plasma. After that, we do the air fluid exchange. We do the air fluid exchange, then inject the autologous plasma over the optic disc pit, and then we place the patient for 10 minutes for upright position and then face down position. This is Vision improved up to 624 after 2 months. This is the OCT. You see, initially it was 700. Now the this OCT central macular thickness decreased up to 537. This is case 2. The 48 years old male present with 160 visual acuity. This is the OCT of the patient. We use collagen plug. In this case, there are different techniques. So I used to do different maneuver to manage operative spit maculopathy. Initially autologous serum, then I tried this collagen plug. We hold it. And then apply over the pit. It's a very delicate surgery. Sometimes it slips from your forceps, but you have to regrasp and then insert into the operative spit. This is the post-op OCT of the patient. You see, this is the case 3. 20 years old lady present with counting finger vision. This is the OCT of the patient. Periop, very large operative spit. We perform the vitrectomy. After inducing the PVD, we perform ILM peeling, and the edge of the ILM is inserted into the operative spit. I used to do different techniques. First autologous serum, then this collagen plug, then I used to try this ILM plugging of the ILM into the operative spit, and you see the results. Fast forward नहीं होता इसमें.
क्या कह रहे हैं?
फास्ट फॉरवर्ड नहीं होता, मतलब मैं इसको थोड़ा सा आगे ले जाऊँ. चल ले. So we elevate the flap of the ILM. You see, in this case, I start elevating, grasping the ILM from the temporal margin of the macula. But in the next case, you see, I just took the ILM from nasal side of You can see temporal margin of the disc. Yes, I peel a whole ILM and then trim it and then insert into the operative bit and then perform the airflow exchange. Place it, bring it up to the disc margin and up to the pit. और सबर आजमा काम है. We cut it, trim it, and then place it over the pit and then perform the airflow exchange. This is the post-op OCT. Patient vision improve up to 612 from counting finger. This is fourth case. A 15 years old girl, she is shortest. The very important case. 15 years old girl present with the pre of 636 vision. She is in class 9. Abhi wo exam de rahi hai. This is the photograph. This is the OCT. This is the operative spit. I perform the vitrectomy. Actually, इसमें video जो है सर fast forward नहीं हो रही. ये तो बड़ी अच्छी वाली केस है. मैनुअली नहीं हो रहा ना. यार इसको जरा करें. हाँ ये ऐसे कर. Now you see, in this case, I take the ILM flap from the temporal margin of the disc. पूरी completely मैंने tear off नहीं की, क्योंकि सिर्फ pit को cover करना था. ठीक है, तो पहले बता देते यार ये तरीका. सही, चलो. Trim the this flap. Then insert it into the operative spit with soft tip cannula, perform the airflow exchange, and then put the gas. This is the OCT, post-op OCT. This is OCT, and this is the vision. Vision improved up to 6.9 with plus 1.5. She is giving her class 9 exam right now, and she is very happy. Alhamdulillah. Thank you very much. So there is also my second presentation. If you okay.
Now, I would request Dr. Rafiza, he is going to talk about development in the macular.
Assalamu alaikum ji. I am Dr. Aziz Jan Bashir and I will be talking about one of the techniques of macular hole surgery where we use a modified inverted flap technique. I have no disclosures to make. So there are different approaches to repairing a macular hole. It all depends upon the surgeon's expertise and the size of the macular hole. It can be a conventional ILM peel, an inverted flap or a temporal flap. Some people use a lens capsule graft, amniotic membrane grafts, a retinal autograft like Dr. Muhammad used for a very large macular hole. And the one I'll be talking about is a multi-layered flap, which is also known as a petaloid inverted flap technique or an envelope flap technique. Basically, with small holes, whatever approach you use, it doesn't matter, the usual success rate is very good. But with large macular holes, it gets tricky because with holes more than 500 or 800, 900 micrometer size, the success rate really goes down. So all these techniques have been devised to address that issue. The temporal flap has a very good success rate, and retinal autograft has its share of complications, but generally it has gained traction and a lot of people have been doing it. So the multi-layered flap technique is a relatively uncommon technique where we make different layers, multiple layers of the ILM and place it over the macular hole. There have been a few studies. One was done in India where they took patients of large macular holes with average macular hole size of 717 micrometers, and after surgery 93% of them closed with type 1, had type 1 closure, and 5% of them had type 2 closure. So that is 98% success rate for hole closure. Another study that I looked at also had almost 97% success rate. So this is an ongoing study at our hospital, and I haven't added my data because it's still in progress, and once it's complete, I hope I'll be able to present it at the next conference. So we'll go to the surgery. So after doing core vitrectomy and injecting triamcinolone, I do pause. Induction of PVD, completing the rest of the vitrectomy. After staining the ILM, what we do is start in a circumferential pattern. We lift one flap and pull it up to the edge of the hole and leave it there, covering the area of the hole. Are we able to appreciate the flap? I don't think so, sir. बड़ी अच्छी नहीं आ रही. So what we are doing is we lift a flap like 2-3 clock hours of it and pull it towards the hole and just put it over the hole. Then another flap, and then another flap like flower petals. So, or an envelope like we close the envelope. So. जी बेहतर, शुक्रिया. So basically, sir, I'm doing the air fluid exchange. So far, sir, we have recruited 12 patients, and all of them had a macular hole of more than 500 micrometers, and the biggest that I have done up till now is 950-60 micrometers. So all of them have closed, and not one of them was persistently open. So I'm hoping for good surgical output, and I hope I'll be able to present it next time I'm here. Thank you very much.
Now I would like to request again Professor Faisal Murtaza, and he's going to talking about recurrent macular hole and its management.
Thank you, Mr. Chairman. My next talk is on surgical management of recurrent and persistent macular hole. No financial disclosure. Full thickness macular hole is defined as full thickness break within the fovea that can cause a significant decrease in vision. Annual incidence is 4 to 8.69 eyes per 1 lakh population. The primary closure rate for macular hole is greater than 90% with current methods, which consist of pars plana vitrectomy with or without ILM peeling. After closure, macular holes may reopen in approximately 3.3 to 9.2% of the cases, and larger holes are more likely to fail primary surgery. In one study by PVRS and Wong, reoperation on reopened macular hole resulted in anatomical closure in 100% of 21 cases. The risk factor for macular hole surgery are persistent vitreal and epiretinal traction, chronicity of the hole, inadequate gas tamponade, large macular hole, and high myopia. There are different techniques like vitrectomy with ILM peeling and gas, with ILM flap, lens capsule transplant, autologous retinal transplant, amniotic membrane transplant, and autologous platelet concentrate. ILM peeling was first introduced by Kelly and Vandal. With flap was introduced by Michael Veska. Lens capsule transplant was introduced by Chang and Yang. Autologous retinal transplant was introduced by Grival and Mahmood in 2016. Subretinal blap was performed by Meyer et al. And they achieved 85.4% closure. Amniotic membrane transplant was first reported by Rizzo et al. And relaxing retinal incisions were performed by Charles et al. And they claimed that 83% of the eyes were successfully treated. Autologous platelet concentrate was introduced by Godric et al. In macular hole, and they said that the macular hole closure was in 95% of the cases. This is 60-year-old female present with decrease in the vision in the left eye for 5 months. She was only eyed. In the right eye there was bullous keratopathy. In the left eye vision was 3/60, and there was full thickness macular hole grade 4. This is OCT of the patient. You see the size of the macular hole is about 835 microns. First surgery was performed, ILM peeling with gas injected. Post-op surgery, you see there was persistent macular hole. Then we decided to perform the second surgery. In this we did the vitrectomy. इसको उसको मैं ताकि मैं जल्दी कर दूँ, टाइम नहीं है. Because she was only eyed, we did vitrectomy. We stain with BBG. You see ILM, there is no ILM on the macula, so we decided to do the relaxing retinal incision with the scissor, and we did the radial cut over the superior and inferior margins of the macular hole. This is an important step. During this we have to increase the height of the bottle so that we should not encounter the bleeding. You see, after these radial incisions, we perform the air fluid exchange, and then we inject autologous plasma over the macular hole, and then inject the gas. आगे चल, उधर करो. First follow-up of the patient. On second follow-up, patient macular hole closed and vision is improved by minus 1.75 diopter up to 6/18. She was only eyed and she is very happy. Thank you so much.
Thank you very much, Professor Faisal Murtaza. Now, if there is any questions from the audience, please feel free. From any of the speakers, please.
Very nice talk. About the previous talk, the first two cases you were doing in those cases you adopted this split. उसमें आपने वो peel नहीं किया हुआ. उसमें सिर्फ जैसे आपने you put the.
Yes. In first case, I just did the induce the PVD, and after inducing the PVD, I put the autologous platelet concentrate over the pit. In second case, I didn't do any peeling. I used to use this collagen plug and insert
directly on the pit.
Because the main thing is we have to create a barrier between the subretinal space and subarachnoid space. Because we think that the fluid is coming from subarachnoid space. So we create a mechanical barrier. See? So we put the collagen plug and you see the results.
Second thing, is there a place for, after doing this procedure, laser of any barrage, laser or?
I didn't perform laser.
Yeah, that's.
Never a single case.
Faisal? Ahmad?
Please use mic.
Yeah, so the second case had only retinoschisis without neurosensory attachment. So
there
at this stage,
attachment.
I would just follow up and not do surgery. Because most probably at this stage, the vision was still okay, right?
No,
What was the
there
preoperative vision
was
of the
serious
patient?
retinal detachment, and it is improved up to 6, you can say 24 in this patient, and it takes time. It doesn't dramatically improve the vision. It takes almost 8 months, 9 months, or even 1 year, because the SRF is very subretinal fluid jo hai, it is very viscous. So it takes time.
And for the eye peeling, in these cases, fovea sparing eye peeling is indicated, because if you do eye peeling over the fovea, you may induce a macular hole. And if you get a macular hole in this case, it will be very difficult to fix again.
But there was no macular hole.
I mean eye peeling may induce a macular hole. So do it fovea sparing.
I think what Dr. Ahmed meant to say is that because it's a very thin over the fovea, if you peel, complete ILM peel, you can create a macular hole and it may not close. So it's better to do foveal sparing.
You see, in my case, there was no macular hole.
Yeah,
Even after the 6 months follow-up, you see the OCT of the patient, and there was no macular hole.
Yes,
Firstly, he's just suggesting, he's not talking particularly to about your case. Regarding, thanks, Ahmed. For your case with the plug, it looked quite long. Did you put all that in, or did you trim it, or
goes in.
it completely gone in, all that?
In, yes.
Right.
What was your feel? It was going in.
I have tachycardia. I have very tachycardia at that moment. You know, I saw first Kehkashan perform this case.
Yes, but
so I learned from him and then performed.
That was the collagen plug, or that was
in my case it was collagen plug.
yes, but
that was different. That was a plug of same size, but here it's longer. That's why we were asking that.
we thought you were going through and through out of. Okay, thank you very much, Faisal. So if there are any, please, Dr. Naveed.
Thank you very much. Nice presentation. Actually, I just want to share my own experience. I have a few cases. I am using amniotic membrane as well, and other few cases I use the ILM graft. ILM, just make an ILM from the area and then fold it and then just push it into the pit. So both cases work well, amniotic membrane as well as ILM. So you can also try, but not. I did not try this plug at all because of fear of bleed or something like that. But you're lucky you have no complication with.
But in my series, I am very. In my experience, I think ILM flap is very fruitful for these patients. Or the cases in which I perform the ILM flap and plug it into the disc pit, they perform very well, and their vision is improved dramatically. So my experience shows that my patients improve with ILM peeling or very dramatically.
So you drain or not these fluid?
No, never.
Never drain. Just put gas and post-check. That's
because the literature says you have to wait for up till 1 year. Even after 1 year, it takes 1 year to resolve. So no need to drain the subretinal fluid. It's very viscous fluid, you know.
So you were actually one of very fortunate surgeon. The patient improved from counting finger to 6'9", I think.
6'9".
This is. I hope she stays like that.
636 to 6'9".
6'9".
This is probably the fresh case. If the case is old, it depends on the duration actually. If the patient present early, then the results are very good. But if patient present late and you are doing your surgery at a late stage, but definitely there is some issues and vision is not very good. So time matters a lot.
I think optic disc pit is such a condition in which different things have been tried. But to be honest, usually what I do is I just induce PVD, make sure there is no traction. I do ILM peel, put gas,
and I didn't have any failure so far. So different things keep on working. So yes, if I think the point Ahmed mentioned, FOVI sparing is important, because when you're doing over there, you can create easily macular hole. So one patient I had macular hole where I peeled, and later I did ILM plug for that as well, and the hole closed. But yeah, that's a learning point. But different things have been tried,
Yes.
and
So in the
laser
last-
is, I think, gone. Laser people are. Yes.
Just the BVD only.
Yes.
I did 3 cases, just BVD only.
Yeah.
And yes.
Yeah.
And I did 2 cases with any peeling.
Yeah.
And actually the vision of the 3 cases with just the BVD
Right.
improved more than and the fluid absorbed it more faster than
Yes.
the case with ILP. So just the BVD can solve the problem.
Yeah, and I think important part is not to drain, because it will settle. Its fluid will take. Rahman wants to ask something.
It's not just the PVD, but also sometimes it's good to stain the membranes at the
Yes.
optic pit, and you know, you
And
can
you
see
remove
those
those
membrane with membrane blue and dual, and actually with the ILM remove those membrane, because those
That
are the
helps.
ones that are keeping the quote unquote valve open, and you just do the
Yeah.
PVD and it actually.
And I think the purpose of doing ILM peel, you want to make sure over the disc that all traction thing is gone. So that's why if I do peel, I peel it over the disc area where as Rahman is mentioning. So yeah. Any other comments? So
Thank you very much, Faisal. So we had a talk from Dr. Amir about subretinal fluid dissection for macular hole. Then challenges in macular hole. We saw a very good case, well executed surgery of autograft for macular hole by Dr. Muhammad Ahmad Tawfiq. And then again challenging cases of optic disc pit with maculopathy and recurrent macular hole and its management by radial relaxing incision by Professor Faisal Murtaza, and our young star who told us about how to envelop the macular hole, Dr. Aziz Jan Bashir. Whenever there is challenges, there is always when there is no effective first line option, there is always new innovations, and people will try different techniques and different new procedures. When there's one's takeover, then all these innovation, rest of them, they go to the backstage actually. And if an effective option is there, then no other innovation usually comes. So thank you very much. Thank you very much, everyone.